Okay. Ladies and gentlemen, esteemed colleagues and distinguished guests, I'm Dr. Zhang, the Vice Superintendent of Zhongshan Medical University. Welcome to Zhongshan Medical University. It's with great pleasure and excitement that I welcome you all to the Taiwan Vascular Therapy Live 2024 held in Zhongshan Medical University. Today, we gather not only to explore cutting-edge advancement in vascular therapy, but also to foster collaboration and strengthen our community of healthcare professionals and dedicated to improving patient outcomes. Over the next 2 days, we'll have the opportunity to engage with leading experts in the field, participate in insightful discussions, and witness live demonstrations of the latest techniques and the technologies in vascular treatment. These sessions are designed to enhance our knowledge and skills, enabling us to provide the highest standard of care of our patients. As we embark on this journey together, let us embrace the spirit of innovation and collaboration. Sharing our experience and insights is essential for our growth as professionals and for the advancements of our field. I encourage each of you to partake actively in the discussions and the networking opportunities that this event offers. Thank you for being here and for your commitment to excellence in vascular therapy. Together, we can continue to push the boundaries of what is possible and make significant strides in improving the lives of those we serve. I wish you all a successful and fulfilling conference. Thank you. And let's invite the next opener, the chairman of the Taiwan Society of Interventional Radiology, Dr. Zhang. Dr. Zhang, please.
Good morning, everyone, and professors and doctors. And I'm the president of TSIR, and I welcome all of you to this TVT event. And it's my great honor to welcome everyone here, and we will share our skills and lectures together. And thanks, Professor Xu Zhonghe, to create this platform for all doctors to having collaborations together and learn from each other. And today, as an interventional radiologist, we also perform 2 topics, the prostate arterial embolization and the TAMI. So I'm looking forward to the live demonstration in this afternoon, and I hope we'll get something from you. And at the last, again, I welcome all of you to joining us, and I wish this conference great success. Thank you. And I would introduce the next Professor Ke Bo-ren for the welcome opening.
Thank you. I'm Dr. Bo-ren Ko, vascular surgeon from PW Clinic in Taipei. It's really happy to be here in the end of the year to join the prestige activity. This is very, believe me, this is very special, very good activity. We have waited for a long time, although this is second time. I think in the future will be more prosperous. It's really special. In this meeting, this will be a multi-specialty. We will cover artery disease, venous disease, and also a very important field in Taiwan, dialysis access treatment. And of course, you may see that this is a Congress covers all specialties, intervention radiologists, cardiology internists, and also surgeons. Quite happy we work hand in hand together. And very important thing is, we physicians in Taiwan, no matter in which level of organization you are working in. Like me, I work in the clinic now. Those experts from the medical centers, we work hand in hand together for our patients' welfare. So with the support of the hospital and our chairman's hard working, I believe that this will be a huge success. Thank you.
Good morning, everyone. Can you hear me? It sound okay?
Yeah, it's okay.
Okay, so good morning, my dear friends, and I'm glad you can come to attend this two-day course TVT lab demonstration, and we are excited and already prepared 26 live demo cases in China Medical University and the Changhua Christian Hospital, and we hope everyone can enjoy the lab demo course. And besides, the official language is English. However, we encourage to ask questions or share experience also in Mandarin is allowed. That is okay. 如果中文分享觉得更有意思，也都很欢迎这样。So hope everyone can enjoy the this two-day course, and I forget to remind the operators because we are educational course, so it is certainly important to educate all of us how to overcome those difficult cases. However, it is also an educational point to know when to stop if there's really a very difficult thing, or maybe need to shift to surgical choice is also okay. So so 也不要太勉强哈。So patient safety is the first priority. Okay, thank you everybody. And we have a gala night tonight, and we can drink tonight too. So welcome all of you to come here. Yeah, thank you. 谢慧主先。
Okay, thank you, President Xu. Okay, ladies and gentlemen, welcome to the Taiwan Vascular Therapy Live this year. I'm Dr. Zhang from Dalian City Hospital, and I'm a vascular surgeon. Let me introduce all my co-moderators and the commentators. This is Dr. Rockman, radiologist from Thailand, and Dr. Zhang Zhiyang, vascular surgeon, and Dr. Zhang Ruizhi, vascular surgeon, and Dr. Li Minfeng, radiologist, and Dr. Wu Chenxue, cardiologist, and Dr. Chen Yizhi, cardiologist, and Dr. Huang Zhaokang, cardiologist, and Dr. Huang Bosen, also cardiologist, and Dr. He Zhiyang, Dr. He, cardiologist, radiologist, and Dr. Wu Nanjun, vascular surgeon. Okay, so you can see today we have very tight schedule, and in these 2 hours, we are going to demonstrate 7 cases. Yes, you will know President Xi have very great ambition. Okay, so it's room one, Dr. Wu Dianyu.
Hello.
Okay, not yet.
Yeah, already finished 1 case. Okay.
Okay, so how about room two? Room two, Dr. Pan.
Next.
Okay. So are you okay for demonstration?
Room. Next, please.
Yes. Hello, everyone. Can you hear me?
Okay, yeah, we can hear you. Dr. Pan, please introduce all your colleagues. and let us know what case are you going to demonstration today.
With me, we have Dr. Lin. Also, we are going to have patients with MTS. Our approach is for popliteal vein punctures, and then try to cross the lesions, and then after assess the lesions, we plan to have balloon angioplasty and stenting. We just start the procedure now, plan for the popliteal vein puncture. We are trying to find a segment of the popliteal vein which is good for puncture. Can you see the ultrasound?
No, yeah. Okay, we can see that now. So are you going to puncture popliteal vein?
Yes, we are trying to find a good segment of the popliteal vein for puncture.
So could you introduce the patient for us? How about the history of the patient?
Do you know that? I think the patient present with chronic venous insufficiency with with some pigmentations and also healed ulcer over the ankle, and then subsequent CT scans show there's got the eyelid vein over the left side is occluded, which is compressed by the eyelid arteries. But just today we do the dual PET scan. Actually, there's also some chronic thrombus on disease segment over the superficial femoral vein. So that's why we decide to go with popliteal vein puncture to have a better delineations on the anatomy. Yeah, the local, yeah. 有点痛。
Okay, so do we have yeah, because it's just beginning. So is there any room ready for demonstration?
Yeah, we just start it because.
And how about in Zhangji, Dr. Kim and Dr. Yu? Okay, Dr. Kim?
Yeah, I can see you.
Yeah, you are on the air now.
Yeah, thank you very much. I am Song Kim from South Korea, working at Busan in South Korea. It is my great honor to visit Taiwan again. This is my second time in Taiwan Live. Thank you very much for inviting me as a faculty member of this meeting. Oh, I can see you, Soracha. Got it, thank you. I will introduce my colleague, Dr. Yo. Yes, please. And introduce yourself. Yes, thank you very much. Let me introduce let Dr. Yu introduce the case of this patient. Please introduce, please. How old? Okay, I see. Okay, yeah. You introduce.
Artery EVT with arthrorectal by jet stream, and a DES was placed. This time he presented with left leg claudication and numbness. ABI
years old
done at the
patient
time of the EVT
suffering
in
from the
2023
ESRD,
was
and the stage of renal disease
0.32
and
for his right
hyperlipidemia and
leg
hypertension.
and
He is suffering
0.66 for
from
his
the
left.
left claudication. The
His
ABI
pre-procedure
showed
CT angiogram in
0.66 in
October
left side.
2024 showed
On
left
CT angiogram, there
superficial
was
femoral artery
some
occlusion.
disease,
This will be
especially in
our
the distal
target
separate
today.
pumping artery, and there are several classifications, severe classification in the distal separate pumping artery. You can see on CT angiogram. Yeah. On angiogram, I think it is possible to use the jet stream and followed by the polyvalent, named as a large. It is possible. So, would you like to show me the angiogram of today? On angiogram, there is no disease in the CFA and the proximal CFA, but there is a fan-track sign with heavy classification, such as in patients with ESRD patients. And let's move to the distal side. Okay. There's some disease in the middle CFA, but it is not good for treat. But from the 80 to the 118, there is severe classification with the luminal loitering. After that, the best by guide wire to the tibial artery and check the angiogram. There's no blood flow to the foot, but there is a full occlusion of anterior tibial artery. And then let's move to next image, please. Next image. We check the IBUS. Please show me the IBUS on the screen. We check the IBUS at the first. I check the P2 side, and second, I check the IBUS at P1 side, and then finally check the IBUS at the distal CFA. Would you like to show me the P2 segment of IBUS? Can you see the IBUS? P2, please.
Not yet for the IVUS.
Not yet. Okay. Can this move to the?
Yeah, please show us the IVUS image. Okay.
Okay. This is a P2 side. There is heavy classification. You can see from 6 to 9 with luminal lowering, and there is somewhat not diseased area at the P2 side. Move faster. And there is some superficial calciums with some luminal lowering. And here is a good tight point at the P2 side, proximal portion of P2 side. Here, heavy classification. The arc is more than 118. Let's move to P1 side, please. I show you the P1 IBUS image. Move faster. This is a distal side to P1. Go faster. Here is nodule calcium in the P1 side of the proximal part of P1. Here is a very severe side. As you can see. Here, stop.
Oh, yes.
Stop, IBUS. Back, one more. Okay, here. No. Just go back. Go forward. Okay, here. Yeah.
Yeah, it's very tight
Here's
lesion.
Here is the most tight regions in the P1, proximal side to P1 segment. The arc of the calcium is more than 118, with the severe luminal narrowing, maybe more than 80% of luminal narrowing of the proximal CFA. So I think in my personal experience, the calcium arc is rather than the 118. I prefer just the specialized balloon to lesion purification with cutting balloon or other storing balloon. But calcium is over than the 118 degree with the severe luminal narrowing. I prefer laterectomy. This side, the somewhat eccentric calcified frag in this CFA and the P1 side, but I think it is possible to use the jet stream. So that's why I select jet stream. So would you like to any strategy or a recommendation to me
So,
from panelist or moderator?
Dr. Rockman, do you have any recommendation? Yeah, please.
Hello, Dr. Kim.
Yep.
Okay, Sorcha here. Total agree with you to use some special device for vessel preparation, especially in the calcified lesions. Somehow very tight calcified in this case. If we balloons alone, maybe we end up with the severely dissection, and we have to stent in this area. And in some area we don't want or no stent zone area, so we need some special device like the atherectomy device, depend on the directional or rotational. Yeah, I agree that we need some rotational atherectomy device. One question, in every case, before you use the jet stream or the atherectomy device, you apply or you advance the IVAS before in every case, or in some case you recommend or any benefit of using IVAS before you use the atherectomy device?
The role of the IVAS in the SFA is, I think the two is important. First one is for good prognosis to checking the vessel size, especially focusing the EEM diameter is important. But in my personal experience, I did not use IVUS in just the stenosis region. But in CTO region or heavy calcified regions, I want to check the IVUS before procedure. There is two reasons. First one is the wire locations. And the second one is the calcium arc and the depth of the calcium. It is important. But in case with the deep-seated calcium in the vessel, it is very hard to treat with the jet stream or directional atherectomy. In that case, just the balloon is okay, I think.
Okay, thank you, Dr. Kim. Please keep going, and we are going to another room. Thank you.
Yeah, okay, thank you very much. Thank you.
Now we move to Zhongguo, room 1. Dr. Wu Dianyu just finished the IVC filter retrieval. Dr. Wu?
Yes, please.
Hello.
Yes, we can hear you. Please.
Today's 3 case is a difficult retrieve case. Maybe we can see the brief history, please.
Hello, good morning, everyone. I'm fellow from China Medical University, Taichung. Welcome to Taiwan, all the experts from Japan, Korea, Indonesia, and Singapore. We have total 23 cases in 2 days. And here are some of the cases from CMUH. Let's see. For the first day, this is the first case, which is a case of the failure to remove the IVC filter. The operator will be the Dr. Wu Dianyu, and the assistant will be the Dr. Lu Zhongrui. The patient is a 75-year-old female with the past history of diabetes, dyslipidemia, maternal syndrome, and acute left leg DVT in 2023, for which she received indigo angiojet and standing. Also, IVC filter was put at that time, is with failure to remove the IVC filter. Also, the same operator and the same operator, Dr. Wu, and the assistant, Dr. Lu. And this is also a 69-year-old female with the maternal syndrome with DVT of the left leg, for which she received the ECOS standing and IVC filter. And we failed to remove the IVC filter in May 2024. Here is the image. Here we can see some failure to retrieve the IVC filter even with the follow assisting.
不要直接猜，不要犹豫，直接猜啊！只要要的东西就直接猜。
Okay, Dr. Wu. So can you show us how do you remove this very difficult IVC filter?
I think the IVC for a long time maybe inflamed with vessel wall and the sclerotic change. So it's very difficult to retrieve by the traditional pathway. So we have to try to the handmade technique, just like use the looping wire to pass the IVC filter, and then we use snare and capture the wire. Then we can make a loop here, and then we just use a tiny force. We can just retrieve it, and from the objective way, the position, and then we can retrieve it to large sheets. Okay, just like the first case. Can we see the first cases? 我们放下上第一个 case 好不好
OK， 我们换去。
这个先出来吧。哦，在打着。可以，我先打。
So, Dr. Chen Yizhi, do you do CT scan before you are going to remove the IVC filter to see if the... Okay, so any our panelists have any experience to remove this difficult IVC filter? Do you do CT scan before removal? Dr. Li Minfeng?
In most conditions, we don't do CT scan. But for the cases we cannot remove IVC filter, yes, of course we do CT scan. Sometimes you can see the hook of IVC filter is attached to the IVC. Well, in some extreme cases, you can see the hook of IVC filter is is penetrated IVC wall and go outside. Yeah, in this condition, maybe we will use Olympus or forceps and trying to hold maybe the neck of the IVC filter and violently to grab it out. Yeah, yes. But sometimes it's very difficult. Yeah. But also we ever see the tip, the IVC field penetrate from the IVC to the aorta. Yeah, or even penetrate the ball.
Okay.
So to confirm the routine remove the IVC filter, you don't do the CT scan unless the complicated case or the complex case, right?
Yes.
And the question is when you put the IVC filter, you have the period of time of schedule of the patients to remove?
So do you mean before putting IVC filter, use
No,
CT
I mean after you put it and there is no indication already. You schedule for the patient to remove for how long?
No.
2 months, 3 months, or?
You mean the period between remove and the insertion removal? Actually, we usually remove the IC filter within 1 month. Within 1 month. Yeah, within 1 month. As quickly as possible.
As soon as possible.
Yeah.
Very important.
To prevent the complication.
Okay, so Dr. Wu just showed us a very useful technique when you cannot grab the hook.
看上面，来出来，不是。
Yes. Yes, I'm.
Hi, Dr. Chan.
I'm
I
Chan.
can recognize you, right?
Yes. It looks like the challenging cases in the morning. That I believe in the first session, and I'm happy to see that it will be challenging.
Yeah.
And we have tried a few attempts, but I must say sometimes they're very challenging, and we did not was not successful to remove the certain filters. Well, regarding the loop technique, as you can see that sometimes it's not it's not the neck. You will hook some of the legs, right?
Yeah, sometimes we hook.
Sometimes. So to my understanding, some doctors try to remove, but they fail before.
你换一个角度看一下，可以吗
In this
？Yeah,
case,
this case before.
Yeah, okay.
Other doctor tried before, right? So it seems
looks like
broken, right?
Before the removal, the device is also straight. I see patients with tilt filter. The neck is possible in the renal vein. So it's, sometimes it's very challenging.
Yeah.
I'm Dr. Xu. Can you hear me?
Yes.
Yeah. In fact, I'm the one who failed to trap the IVC filter last time. Yeah. Sometimes we also use this technique with 12 French shears, but sometimes will be successful, but sometimes the IVC filter will be distorted, and so we do not like very love to use this kind of trapping procedure. So our modified procedure is to use to puncture the femoral vein and then advance the wire into the between the vessel wall and the tilting IVC, and use a balloon to dilate and trap the balloon from jugular vein, then trap it out. Yeah.
Okay. Can somebody tell me what the sheath is? What big sheath is from next?
This is now. Can you use 20 French shears?
20 French shears. What kind of shears? 20 French shears.
From maybe from Medtronic or Gore. They all have more than 20 French shears.
So what kind of shears do you use? You are using the big shear from the neck.
The first case is from Medtronic, right?
Medtronic, right?
And yeah, we puncture the neck, the right internal jugular vein.
You people use 20 French from the neck. That's that. You use. You haven't tried it? No, no comment.
Okay. Room one, Dr. Kim just finished the gesturing atherectomy. So, Dr. Wu, please keep going, and we're going to move to room one. Okay, Dr. Kim, I heard that you just successfully finished the gesturing atherectomy. Please show us.
Yes, I finished the gesturing with the only breakdown. Please show the gesturing image. As I was finding, I think that there is a severe calcification of the luminal narrowing in the SRS around 190 to 118. So at that time I use first I use gesturing atherectomy.
So did you
use
balloon predilatation?
I already passed 3 times gesturing with the breakdown. Only contact cutting. This is angiogram. So So after polishing of the lesion with the breakdown jet stream, with the blade up, it is very hard to advance the jet stream at the site of the P1 segment. So I did small balloon angioplasty for the P1 site for passing the blade up jet stream. This is my situation now.
Okay, so what kind of...
I will try to one more jet stream with the blade up again at this point.
Okay, I can see the Navy 6 filter at this side. So,
yes,
Dr.
right.
Kim, because P1 segment is you should go through the abductor's canal, and
yes, right.
yeah, do you have any tricks to tell us how to avoid rupture?
Oh, we need precaution to do not make preparations. Sometimes there is no way to prevent. Just precaution is important with a slow progression.
Our panelists, do you have any comment, Dr. Huang or Dr. He?
Yes, please.
About the jet stream? Okay, so you just finished the DCB treatment, right?
No.
Not yet.
I'm going to use blade up jet stream. Blade up.
Okay.
Now.
Okay.
Yep. I show you. After blade down jet stream, there is some resistance to use blade up jet stream. So I did plain angioplasty at the P1 site, and now I want to use blade up jet stream.
Dr. Kim, thank you for your sharing. That's, to my understanding, you're the first pass without flare-up. So I'm going to flare up the device and do the jet streaming again. Yeah.
Yes, I frequently use 2 times blade down and 2 times blade up. In my personal experience, I preferred. But today, I use 3 times blade down pass for this patient. Hold the wire, please. Let's move to proximal side.
I believe it is the talk in the, later that will discuss what kind of device, what's the benefits and the risk of the devices. But I believe just one is, to my understanding, is straightforward. It's a rotational device.
But
as you can see the screen that most of the calcium they not easily remove by the device, right? They cannot remove the calcium. It go to the soft part. It doesn't go to the hard part, right?
I think is we cannot remove all of the calcium, but we can achieve the luminal gain without severely dissection. I think the proposal is just
Yep. Yeah. Let's go.
I have a crazy idea that possible we can in the future use the
legs please.
Using the shockwave device to break the calcium. Then we do the gesture. That means that maybe sometimes you can do that both. No, I'm not talking about money, but I mean it's possibly.
Yeah, we use shockwave first and then use the jet stream where we have lots of debris. I'm not sure.
Let's.
Okay.
Okay, let's go.
Yeah. So now it's played up.
Yes, right, played up.
Okay.
That's the problem.
So Dr. Kim, please keep going. We are going to the mini lecture. The first mini lecture is from Dr. Lin Shu Han. She will present the role of DES, sirolimus, or DEB, sorry, in lead case.
Thank you for the very kind introduction. I am Donna Lin from Shin Kong Hospital, Taipei, Taiwan. And it is my great pleasure to be here. And for the interest of time, I only have 6 minutes, but I think there's a lot to discuss regarding sirolimus. These are my disclosures. So just to remind, I think there are some young doctors here that we have come a very far way from like year 2000, where we have very bad primary patency with just plain balloon angioplasty in the FemPop. And this is primarily because of the advancements of DCBs. Although they were, as you can see on this slide, these all were trials from paclitaxel balloons. So why do we still need to discuss about DCBs today? Primarily, although there has been a lot of discussion regarding the Catano's meta-analysis, when they reported this in year 2018, there has been some signal regarding increased mortality with the use of paclitaxel DCBs. So since then, we have been thinking about the safety of these drug-coated devices, although we know now that the mortality issue is probably a matter of statistical problems. Anyhow, regardless of the safety issue, the outcomes of patients with chronic limb-threatening ischemia is still not optimal at this point. You can see from the BEST COI trial that there is still about 1/6 of these patients who go on to have a major amputation and maybe other major limb events. If we look at meta-analysis regarding paclitaxel-coated balloons in below-the-knee arteries, you can see that their efficacy are just not as good as their efficacy in the FemPop. So currently, the available DCBs that we have on the market are, as you can see on these slides, we do have 2 types of sirolimus-coated balloons, the Magic Touch and the Solution. And we can see how paclitaxel and sirolimus are fundamentally different in terms of their mechanisms. First of all, paclitaxel is cytotoxic. It causes cell apoptosis, whereas sirolimus is cytostatic. And due to this difference, sirolimus actually does have anti-inflammatory effects and is also highly effective during hypoxia. Another thing about paclitaxel and sirolimus differences is their therapeutic window. So sirolimus has a much broader therapeutic window, leading us to think if a patient is going to perhaps have repeated revascularization procedures later on and are exposed to these DCBs many times, maybe sirolimus would be a safer option. But the problem with sirolimus is that it is not very lipophilic, meaning that the transfer from the balloon to the vessel wall is going to be problematic throughout the entire process. And so coating methods is very important in the development of sirolimus DCBs. We also know that drug bioavailability in the vessel wall is related to the patency after DCB use. This has been seen in paclitaxel-coated balloons also. And the tissue absorption of sirolimus in terms of DCB technology, it is slower to absorb and is shorter, retains for a shorter period. So this is the challenge that we've been trying to overcome. There has been many technologies in terms of sirolimus DCBs. This is just an example from the solution, I think, regarding the micro reservoir technology for sirolimus transfer. Another thing that has been discussed between paclitaxel and sirolimus DCBs is the positive remodeling using paclitaxel. This is not seen in sirolimus DCBs, and whether this actually improves or affects outcomes is currently uncertain. So what data do we have now regarding sirolimus DCBs? Well, there are a number of studies. Unfortunately, many of them are very limited in sample size. So one of this is the ecstasy. This is comparing sirolimus DCB in both FemPop and BTK. Unfortunately, I think they did a great job, but the number of patients enrolled were 55 with about 20 to 30 in FemPop and BTK groups. You can see here that there is a very high proportion of patients with diabetes, suggesting a higher comorbidity group. About 70 to 80% of these patients actually had some type of tissue loss in terms of Rutherford grading. And about 1/3 to nearly 1/2 had a total occlusion. And the ecstasy did not report primary patency in terms of their outcomes. So far, they have reported their 3-year outcomes, but only in terms of CDTOR and major amputation. And you can see how even in below the knee, more than 85% of these patients were free from CDTOR at 3 years, and about nearly 80% of these were free from CDTOR at 3 years. Another study was the Prestige, which also looked at sirolimus DCB, but mainly in the BTK with patients with CLTI. And they enrolled patients, 25 patients. These patients also had a high proportion of diabetic patients and about 43% with end-stage renal disease. And you can see how actually 14% of these patients had a heel wound, which was a marker of poor prognosis. Regardless, in the Prestige, they actually reported more than 80% of primary patency rate at 6 months. And in terms of other outcomes, you can see how freedom from CDTOR was 92.6% at 12 months, which is actually pretty positive. But so far, we do not have direct comparison between paclitaxel-coated balloons and sirolimus-coated balloons in the BTK. This year at TCT, as a late-breaking trial, the Sirona RCT was reported. Sirona RCT compared sirolimus DCB against paclitaxel DCB in patients with FEMPOP disease. They enrolled 482 patients and were randomized in 1-to-1 ratio. You can see how, these patients were about 1/3 were diabetic, so perhaps not such a highly comorbid group. Most of these patients were Rutherford 3 classification, and the lesion length was about 8 centimeters. In terms of their study endpoint, the primary efficacy endpoint was a primary patency outcome, and the primary safety endpoint included revascularization and major limb amputation, etc. For the interest of time, we go straight to the results. You can see how freedom from in terms of the primary patency, sirolimus and paclitaxel DCB were not different in terms of primary efficacy endpoint, and it reached non-inferiority p-value statistically significant at 0.022. Freedom from CDTOR were also similar between sirolimus and paclitaxel DCBs. So to summarize, paclitaxel DCBs have proven benefits in FEMPOP disease, except that their efficacy in infrapopliteal lesions are less certain, and this is primarily the challenge that we have been trying to overcome with sirolimus DCBs. But there are fundamental differences between sirolimus and paclitaxel in both mechanism and pharmacokinetics and dynamics. So how this actually affects their efficacy and safety is unknown. Currently, there are small cohorts, including Ecstasy and Prestige, that reported positive results of sirolimus DCBs in below-the-knee arteries. But when we compare paclitaxel against sirolimus head-to-head in the FEMPOP, currently there seems to be no difference at 1 year, and of course we are looking forward to longer follow-up in the Sirona trial. And thank you very much for your attention.
Thank you, Dr. Lin. Now we are going to the Zhangji Room 2. Dr. Yang Yuanbo just finished his SFA atherectomy case. Dr. Yang, please.
Oh, here. Oh, quite correct. Well, that's a great job. Very positive. Very positive. Yeah. Wow.
Yes, we can hear you.
Okay.
Yeah, please introduce your team and
Thank
yeah.
you. So let's move to the balloonoplasty and followed by the quality balloon. Yeah. Can I have the? Would you like to check the lumen size, EM size of the proximal side? EM, please.
Yeah, please show us the image. Yes.
Back, please. No, not here. Here is here. More. This is more. Okay, got it. More. Yeah, say more. Here's one more. Just more. Okay. Okay, got it. On the 6th. Yes,
also
right.
use the CO2 angiography.
Please,
Next,
please,
下一张。
this side. This is important. In lumen side, just 4 to 5.
再下一
Yes, this is CO2 angiography. We can see the lesion very clear. 下一张。Okay, for this lesion, we use a POBA first. 下一个。再下一个。I use the 6 millimeter, and the length is 120. 下一个。下一个。After the POBA, I use the CO2 angiography to check the lesion. The diameter looks better. 下一个。
So Dr.
I also
Yang,
use the, yes.
Is this a CKD patient or this
No,
patient
no.
allergic to iodized contrast?
No. I just want to show the CO2 angiography for everyone.
Okay.
Yes. And for this patient, according to our experience, when we use the CO2 angiography, patients always complain pain or maybe just like an ischemia sensation. But this time, the patient didn't move anymore. So after POBA, I also use the contrast to make the condition after POBA. We can see the dissection flap over the right side. 下一张。So I decided to use the stent. I use the Illuvia 6 and 120. 下一个。Okay, this is a self-expansion balloon. After deployment, I use the balloon for the post-dilatation. 下一个。下一个。Next. Oh, next. Okay, so I took the image. This is CO2 angiography. The image is very clear.
So
Okay.
Dr. Yang, is this a claudican or this patient is critical limb ischemia patient?
Oh, okay, this is a claudication patient. So my treatment target is left SFA. And the previous image, the left ATA is also total occlusion. But my target is left SFA first. Next. 下一张。
So, Dr. Yang, thank you
Yes.
For sharing the case. I'm Dr. Chen from Hualien Tzu Hospital. So,
Yes.
can we go back and see your CO2 image again? Because when you described, there's a dissection image, but
Yes.
to be frank, I didn't see the flow limited. So why do you want to put a stand? Is any specific reason, or these patients require, or what's the lower, the distal lesion below this segment? Thank you.
上一张。再上一张。再上一张。上。POBA完的那一张。POBA完的，还没有 stand 的。好，左边那个，哎，对不起，上一个。Oh, okay. This image we cannot see the dissection flap, and the flow is okay. Is very acceptable. But I think 下一个。But after I use the contrast, iodine contrast, we can see the dissection over here, and the recoil lesion, if maybe 2 or 3 lesions. So my opinion is maybe I can use the stent for dissection and the recoil lesion. Because of the CO2 angiography, we cannot see the very clear for the restenosis and the dissection flap. 上一个。 and the recoil is not very clear. I think the factor of the CO2 angiography, we cannot see the recoil, but we can see the flow very fast because it's air. Because CO2 is air.
So actually, that brought me the second question is that the CO2 angiography will give us some false negative result and influence our decision, or maybe not. Or you want to routinely check with contrast too.
Okay.
Is there any comments or tricks?
My experience is not so much. So now I just want to learn my clinical experience just like this one. We maybe use the contrast with CO2 angiography, and maybe in the future I can organize the clinical outcome, and maybe I hope I can get the better outcome from the CO2 angiography. But now I cannot do it.
Okay, thank you.
Thank you, Dr. Yang. I'm Dr. Chen from National Taiwan University Hospital. That's the conclusions. It's a challenging anatomy. I see the dissection. I have the PTA and you put the stent. Can I ask what kind of stent you put and what do you make the choice? Is it a drug stent or is it a common stent? And
okay.
Because the question is that current guideline possibility disagree with the best stent, so what means that what the choice and yeah, that's it.
Okay. According to the clinical trials, we know for the SFA, DCB is a good choice for the intervention. And for this patient, I choose the stent because the dissection and the stenosis. And the stent, I choose the drug-eluting stent. I use the Illuvia because the clinical trial of Illuvia, the 1 year or 5 years outcome is so good. So I choose this one.
Okay, so our panelists in this claudican SFA calcium stenosis case will choose DES or balloon DCB or scoring balloon DCB. So Dr. Chen or Dr. Huang?
From my clinical experience, I try to not to put a stent as possible as I can, especially if after the PROBA, the dissection is not so severe. So before the vascular preparation, you can use the chocolate balloon or scoring balloon to reduce the possibility of the dissection. Then if the dissection can minimize, then we can use the DCB. If the calcium plaque is not heavy, is my opinion. But if I do my best, still severe dissection happen, sure he needs stent scaffold. Actually, if the patient can afford, drug-eluting stent will be a first choice, better than a bare metal stent.
Okay, thank you, Dr. Chen. Thank you, Dr. Yang. Very nice case, and we are going to move to Zhang Ji, room 1. Dr. Kim just finished the gesturing case. Dr. Kim. Yes, Dr. Kim, we can see you now.
Can you hear me?
Yes.
Yes, I see. I just finished the jet stream with the blade up, and I checked IBUS. Before 10 minutes ago, there's some problem. Some event was occurred. I show you the result of the atherectomy jet stream. In filter device, you can see the debris, several debris. Can you see? Focusing, please. Okay.
Yes.
Some debris is catched in this filter protection devices. And the event was while stocking. I show you. Why was the stock in the jet stream? So, focusing, please. Why was it stock in jet stream? Here.
Yeah,
Okay.
sometimes this happens. So
yes, right.
How can we avoid this?
Things. Yeah. Oh, Lex is important. When you advance the retrieval of the jet stream, the Lex is important. Lex is the most important to prevent this event. So today, but I have experienced this some special event, but there is no problem. On angiogram, please show the angiogram after procedure. You can see the good flow from the distal separated to the frontier area after directional atherectomy. And let's move to IBUS, please. We check the IBUS.
So, Dr. King,
yep.
do you think the jet stream catheter stuck with the wire because there is kink when you do the P1 atherectomy?
No, not kink. I think there is some problem with the legs during procedure because our team is not familiar with jet stream, but we did a great job. Okay, can you please change to the IBUS image?
It happened to me one time during the jet stream with the NAPSIC. Actually, they recommend the filter device not to use with the hydrophilic coated, and the NAPSIC is the one that the IFU they recommend, but it's happened. I think it's because the rotational create the heat. If you operate, if you activate the catheter long time, it can create the heat and the catheter is stuck with the wire.
That's right. So that's why Lex is important. Can you see the IBUS?
Yeah, but the jet stream, they have alarm system. You just have 25 minutes to do atherectomy, and then you have to stop and rest. So do you think this is too long? Or maybe we should stop before the alarm?
For me, I think is the step by step I create or I atherectomize segment by segment, like the 2 cm, 5 cm, and stop to make some cooling of the catheters. Otherwise, you operate 5 minutes, the whole length. I think that one create the heat and we have some stuck of the catheters.
Okay.
That's right. So, can you see the IBUS, Fred, please?
Yeah, we can see the IBUS. Please show us.
Yeah, Fred. There's a cracked calcium anywhere. Here, cracked calciums. Previous. Okay, so from the 6 to 9. Okay, let's move forward, please. And here is a calcium crack. You can see. And the lumen again, we have. There's a calcium crack from the 1 to 3 hours. There's crack in the 2 hour. And calcium crack in the, this is lumen.
Yeah, it's quite bigger.
Yes, you can actually very nice luminal gain.
Yeah.
Yes, I think so. Let's move to the EM side. I want to discuss about the balloon size. This is the proximal side of the lesion. The EMs, the lumen size is around 4 to 5 centimeter diameter, but in the EM size is 5.5 5.5 to 6. Which balloon is better? 4, 5, 6. Which one do you want to select?
So what is your opinion, your balloon size, all the panelists? You have the...
Which one do you want to use? 5?
Dr. Lee.
According to IVER's findings, the lumen maybe like 5.5, right?
That's
6.
right, definitely.
Yeah. Maybe I will choose. Maybe we can start from the smaller one, maybe 5. Then
5.
Then yeah, if then change to 6 if necessary. Yeah.
Yes, sir.
Yeah. You mean
So
DCB or DCB?
You choose. I mean, he's asking is you use the balloon, ordinary balloon or DCB now?
First, I directed with the plain balloon and followed by the drug-coated balloon. Yeah.
So plain balloon, you are using the 4 means below 5, or use
DCB 6.
Ordinary balloon.
You mean a plain balloon? Plain balloon. Okay, maybe I can use 6. Yeah.
6.
So, or maybe 5.
Why you use the 5?
If I plan to
The
use
DCB?
DCB, maybe I use 5 for pre-dilatation, then I use 6 for DCB. Yeah.
Okay, got it.
So, Dr. Kim, what's your choice?
My choice is 5 millimeter pre-dilatation and followed by 6 millimeter DCB. That is my choice.
Okay, so it's the same.
I'll do it. Okay, thank you very much. Please, 5 millimeter pre-dilatation. Okay, go. Hold the
Okay,
tightly.
Dr. Kim, please keep going. And
thank you.
now we are shifting to the mini lecture by Dr. Zhong Wenrong.
Hold the wire, please. Hold the wire tightly.
Dr. Zhong, he's going to present the method of removing IVC filter. Dr. Zhong? Okay, welcome.
Good morning, everyone. I'm John from Kaohsiung Memorial Hospital, Changchun. I'll share the method of removing IVC field. 10 years ago, we have called this IVC field. So 10 years ago, it's not, it's easier. We just femoral approach, remove it by homemade loop. And then now it doesn't have coated filter. So ideally, we hope we remove it like Mission Impossible, Tom Cruise, from the ceiling and then retrieve smoothly like this. However, sometimes the real world doesn't like the ideal world. In this case, our IVC filter tip tilt after a procedure. After a procedure, the tip moved to the renal vein. So 3 days later, we removed the IVC field. Initially, we removed from jugular vein, jugular access. And then we use the cooked retriever. The loop retriever, initially we cannot reach the IVC field. Then we change to the flower-like snail. It looks very close. However, it doesn't work. Then we use the pigtail to modify the IVC field, and it also doesn't work. And then we use the guiding catheter, try close to the tip of IVC field. Lateral view is very close. However, frontal view is very far. So we changed to a double axis retrieval, like the metal tube dancing girl. We put up a wire from femoral axis, and then use our jugular vein axis. We put a femoral vein puncture first, and then put the wire close to the IVC field. Then inflate the balloon to modify the IVC filter, and then wire go higher, and our snail from the jugular vein to retrieve the wire first. After that, the wire move to the balloon. When we move to the balloon close to the tip of the filter, we differentiate the balloon and put back the balloon and retrieve it smoothly. Total procedure around 100 minutes. So it's too tough. Now we almost never put IVC field. Yeah. In my review, before the procedure, we didn't review it. But after that, we find what we do have many references in the past. Some reference tell us some have below technique, single axis, double axis, dissection technique, and double sheath dissection technique, and laser method. The most used is this single axis. However, it needs a larger sheath to go the wire from the jugular vein with catheter to loop it, and the snail retrieve the wire and like a loop, then the snail go down from the large sheath, retrieve it. However, if it doesn't work like Dr. Wu did in the case, the filter will, the head will tilt, and sometimes the hook will injure. So also sometimes you are not so lucky, the tail will down to the foot. It's very difficult to remove it. And the double axis, our method is also one type double axis. This is a different one. This is a Codis IVC field. It's from the sheath from femoral and jugular vein. Femoral vein, femoral axis grab the low, the low level tip, and from the jugular vein, it hook it, it grabs the IVC field, and then in the same time remove it. And the third method is dissection technique. It uses the myocardium biopsy forceps to remove it, but it needs a large axis, large catheter. And in this way, have additional advantage. It can, if some hook cannot remove, you can use the biopsy forceps to remove it. The fourth method is double sheath dissection technique. It needs two sheaths. The small one is 10 French sheaths, and the large one is 14 French sheaths. And you need to catch the IVC field first in a small catheter. And then when we withdraw the IVC field, the larger sheath can help you to overcome the resist of the hook. Finally, this method may be in Taiwan, maybe no one used. This is my first read from the reference. The Spectronics company and the laser thermal catheter, 12 French. When you catch the IVC field and use the laser thermal to cause some injury of the IVC and retrieve in double lumen catheter like this. The idea is like this. This is a laser thermal catheter. And when you catch it, you can use the laser to create some dissection and retrieve it. And so we have to apologize. Removing IVC field, not always easy mission. So need many methods like this. And the factor to need advanced technique have 4 risk factors. One is if your IVC field deployed too long, the duration is too long, it's difficult to remove, need advanced technique. Or embedded hook, transverse tilt, and leg penetration. So I will share some rare complication about my practice. Because in the past, I think the complication might be some ACEs perforation or IVC perforation. This is a rare complication. When I try to remove my IVC field, I didn't pay attention to my wire have enough support. Maybe it looped in the RV. After I retrieve my IVC field, it's occurred because the wire ideally is straight. However, in the real world, maybe the SVC and the IVC is not straight, not so straight. So if your wire have not strong support and looped, it's cause some complication like this. Yeah. Well, when I remove it, the patient shock. Okay, the patient shock. Yeah, and the tamponade. So immediate pericardial synthesis. And after that, I did some RV injection. You can see here perforation. So this is the reason why the patient collapsed after I remove my IVC field. It's caused by the sheath-related perforation. So the most important is if you want to put IVC field, you need to keep your head straight and never tilt. And you have to pay attention to your sheath, because any ACEs deviation will cause the perforation in the root when you pass it. Yeah. This is my case sharing.
Okay, thank you, Dr. Zhong. Okay, now we're moving to Singapore. Dr. Low. Dr. Low, hi, I'm the Zhang from Taichung.
Yes,
Hi, we can see you.
Hi, good morning.
Good morning.
Hi, my name is Joseph. I've got with me Dr. Praveen and Dr. Sadhana, who are vascular surgeons as well. And maybe if you wish, I can do a short case summary to introduce the case to you, and then we will tell you our progress so far.
Thank you.
So, Dr. Low, please
Yes.
introduce your team and let us
Yep.
know the history about the patient.
Yeah, good. Presentation mode. Yeah, good. Okay, good. So, hi, my name is Joseph. We've
Yes,
got
doctor.
a big team here with us today. Dr. Praveen and Dr. Sadhana are our vascular surgeons. We've got our anesthesia colleagues, Dr. Jocelyn, our OT nurses, our radiographers, and also our hybrid theater. We are the newest public hospital in Singapore, serving about 500,000 population, 11 football fields, about 1,000 beds,
I have it.
and 24 operating theaters.
Where's is this contrast?
So our hospital is fairly new. We've opened up for about 6 months, but when we look at our data, we had more than 100 patients with peripheral arterial disease and diabetic foot ulcers in the first 100 days. They tend to be younger age, about 63 years old, Malay, ESRF.
We are in.
And then the diabetes, they all
Put it to the media.
diabetes.
Yeah.
They all present
Give me the wire.
with a high Wi-Fi score, and they all are
Hakim, save the last one.
by our
The one that I went.
multidisciplinary team, which consists of podiatrists, endocrinologists, nurses, orthopedics, and vascular surgeons. So, in fact, our first patient who presented to us was a patient with a left BKA and extensive right heel gangrene, as you can see over here. So for this patient that we are doing today, he's 65 years old. He's got
Dr. Low?
diabetes.
Sorry, can we see? We cannot see the slide. Can you show the slide, please?
Oh, I'm.
Ask the AD to put the slide on because the slides are being shared.
Or maybe you can focus on the camera. That camera is looking down.
Yeah, but I can't pause it any further, but it's fine. Okay, the two IoT two balloons.
Yes, okay, I think you can see the slides now.
Yep.
Yes, please.
Okay, good. Back one. So the patient today, he is 65, he's got diabetes. He presents with a first and second toe gangrene, as you can see in the picture, with osteomyelitis of the first phalanx. Next slide. So this is his preoperative duplex. It shows a triple vessel disease, peroneal, ATA, and PTA. We will do a ABPI, but often these diabetic patients have got incompressible arteries. So what you see here is a toe pressure of around 60 measured on the second toe with a TBI of around 0.34. So this is the patient, and I will now switch the image to our directory so that we can show you our progress so far.
Will it interfere with mine?
So the patient is planned for a left CO2 angioplasty together with first and second toe reamputation. Are you able? Okay, so you can see our angiogram now. I'll just briefly run you through what we have done. The CFA, SFA popliteal, essentially they are fairly normal. And if we go to, so this is our CO2 run of the distal SFA and popliteal. Some mild disease there, but the money is in the below knee disease. Next slide, forward, next one. Next one. Okay, Ken. So this is a CO2 angiogram, and you can see that we also did a VisiPAC angiogram on the right. We then proceeded to open up the ATA, peroneal, and TP trunk, all to good results. Let's see the final run after the ATA and peroneal. Okay. So essentially, there were multifocal high-grade stenosis throughout the entire length of the ATA and PTA. Open up the ATA with a J 3 mm and a peroneal as well with a J 3 mm. TP trunk we open up with a 4 mm J. And then next one. So then this is the AP view of the foot. it does show the ATA supplying the first and second toes, which are the area of our interest. But we see a reconstituted distal PTA. So we decided to then proceed further to try and rendezvous from a safari technique. Next slide. Yep. So this is the post rendezvous. So what we did was we punctured the PTA distally, bareback CXI catheter, and then used an Astato 018 wire, which has a heavy tip. The Astato went through the PTA, through the TP trunk, and then we rendezvous with our Burr catheter from the top. Next.
So, Dr. Low, did you puncture the distal posterior artery under fluoroscopy or ultrasound?
We did it under ultrasound guidance with a hockey stick probe.
Okay.
Yep. So now you see, okay, so you sort of see my finger where this was where we retrograde punctured. So then we had a through and through access, brought down a jade balloon from antegrade fashion over the through and through access, and then pre-dilated the PTA first. Subsequently now, we have brought down a coyote balloon via antegrade fashion, removed the retrograde wire, and then put down a command 014 wire via the antegrade coyote access. And this is where we are now. So you can see that now we are live. You can see the coyote balloon and the command wire down all the way to the calcaneum. And we are inflating the coyote balloon now. This is a small 2 mm coyote balloon. We just use it as a way to tamponade the distal puncture. You can see a small little fragment of a wire that broke off in our distal puncture because the PTA was very calcified. So after this, now we've got entirely antegrade access. We will then probably open up the PTA with a further 3 mm balloon, and that should be the end of our procedure.
Okay.
Hi, Dr. Lode. I'm Sorasha. I have a question. You have any trick on the CTO image because your angiogram is very beautiful. Don't move. The patient is the general anesthesia or nerve block or local anesthesia, or you have any trick?
So we've got excellent anesthesia colleagues. They have done a regional anesthesia on the patient. They did a popliteal block and also a femoral block. So that helps us in two fashion. Number one, it makes the entire angioplasty comfortable for the patient. And number two, we are also going to proceed with first and second toe ray amputation at the end. So it is, in a way, a single stage procedure for the patient.
Okay. So, so this is plain balloon, right? The coyote balloon. Yeah. So are you going to treat this PTK lesion by TCB?
No, generally we don't tend to do DCB for below knee disease. I mean, for saphenal popliteal, definitely there's evidence for it, but for below knee, we tend to do POBA. And for POBA, our first line will be any form of non-compliant balloon. Coyote here is semi-compliant, and we like it because it is over the wire, and we use it to tamponade our puncture site, our distal puncture site.
Give me a new trium. Yeah.
So now your strategy for the below the knee artery, you use only the non-compliant balloon for below the knees, right?
Correct. Yeah. I mean, we prefer it in terms of minimizing any potential for dissection. And also, at least in our patient population, majority are all diabetic foot disease with calcified vessels. We find that the non-compliant allows us to recanalize or to open it up in a very decent fashion.
Dr. Rowe, I'm Dr. Chen from Tainan, and I have a question. Because this patient is critical limb ischemia, his wound is on the first toe and second toe gangrene. So this patient should be treated below the ankle, I think. So I want to ask is, why do you not choose the fifth ATA first, then go through the dorsally-patelis artery, then try to recognize the plantar loop to fix the plantar artery?
Yep. That's a very good point. So maybe I show you the image again. So initially, patient came in with three vessel disease, ATA, peroneal, and PTA. So as you can see on the image on the left, the previous one on the lateral foot shot. So post-treatment, the ATA and the peroneal had good flow. There is a DP there. We felt that it is more sort of atrophic rather than a stenotic type of lesion. And on the AP view, there is also flow through the AT to the DP to the first and second toes. So hence, instead of opening up the plantar loop, we will spend our time on opening up the PTA so that at least you can have a three vessel runoff. And after this, we'll hopefully see a bigger wound blush to the first and second toes.
Okay, Dr. Low, we have only 1 minute left. So could you show us the final results?
Yeah, we are still in the process of treating the PTA.
I guess you can show the one before that.
You have to wait because you can't show. You want to show the photo?
Yeah.
You know the very previous when I put a balloon in the foot, right?
Yeah. Previous foot, right? Directly.
The very last foot, right?
I think you understood the,
Yeah.
So
Series 40. Series 40.
40. Oh, this is
with my balloon in there,
okay, can. So this is the final run after the AT and peroneal. We are still in the process of reopening the PTA. But as you can see, there is a very good flow from AT and peroneal all the way to the toes. So in a way, we are trying to establish three vessel runoff rather than a two vessel runoff currently.
Okay, thank you, Dr. Low. I believe you just finished the most difficult part. And I believe this patient will have very good result. Thank you.
Thank you very much.
Okay, now we move to Zhongguo Room 1. Dr. Wu Dianyu, he will show us the final result of the IVC filter. Okay.
Yeah.
Terrible.
Can you see the picture of the two cases? The last two, the previous two was successfully retrieved. You can see there. But without complication, you can see that. Can you repeat the picture? 郑晨穿衣服上来，郑晨。再试一次。可以放在前面的片子吗？哎，在这。The first one case was successfully removed by the simple loop technique.
好，90以下再给好了。下一个。
穿衣服上来，然后 puncture 下面，从下面上，对啊，从下面把它拉上去。
有。我们的那也是，那个打开一下那 echo 盖。
Jianhua, are you here?
Yeah, we are still here.
Can you see the picture, the first case?
Yeah, we can see the IVC filter, and you are doing venography.
Yeah, the first.
也是给你 echo 盖嘛，哈，对 echo 过来。
It's simple. This case is simple, retrieved by the simple loop.
因为它是 OPD 的，绝对不会住院哦，所以就是你不能有任何的 puncture 到 error。
So then next.
对，有。
Next picture. So we place the 24 French sheets first, and then we try to make a simple loop. You can use the pigtail. You just cut the pigtail just like this, just like half severe. So you can easily make a simple loop. And then you use one snare can easily catch another side. And then the two wire can be out of the streets. And then we just make a small push. Just can retrieve the IVC filter, just like this. Next. 下一张。
不包，下一个不包。
再下一张。好，再下一张。
这个做出
This final.
Oh.
Okay. Oops, yeah. It's a little heartbeat, right? But it's okay. Okay. Because it's very tight and inflamed vessel, so laceration is not always happen. The patient now is very stable, right? And the second case is very difficult, right? See the second case.
这里 local.
The most difficult is after we make a loop and the wire, retrieve the wire, but the leg broken. So it's quite difficult, right? So fortunately, Jianhua is at Taichung, right?
Yes.
So maybe surgeon back is very important. Yeah, we have a lot of surgeons here, right, in Zhongguo Medical Hospital, right? But fortunately, we captured the one leg and successfully retrieved the IVC filter in front of the caster. And then what we need to do is try to lock another leg, and then we can easily retrieve. So after struggling, okay, see the final, right? 下一张. You see the IVC filter is almost broken. Next.
Set.
Okay, next.
Micropuncture.
Sorry, I see.
Sorry, Dian Yu.
Okay.
We should move to Dr. Kim because he just
Okay.
Oh.
Yes.
Oh.
Okay.
Okay, we'll be back later.
Yeah,
Dr. Kim?
Yes, thank you very
you are
much.
on the air now.
Yeah, I finished my procedure. Please show the angiogram. After traditional surgery, I did plain angioplasty with a 5 mm sized balloon from the distal SFA to the P3. And then followed by the cartilage balloon ranger 5 to 200 millimeters length. I directed from the distal separae to the piece 3 because there are some diseases in piece 3 area. Yes. So please look the please play the image. This is the final image. You can see the good flow from the proximal separae to the infrapunctural artery, and there is no distal embolization, as you can see. This is final result.
Yeah, very beautiful.
Thank you.
And Dr. Chen Yisi have a question for you.
Yes.
Dr. Kim, I have a question. I want to ask, from your clinical experience, how many times atherectomy is adequate for you? Because I know you ever did a great job, over 50 times atherectomy by using the Hook 1. So I think yes, it's amazing because actually we cannot do so many times atherectomy during our clinical practice. So I want to ask for you, your experience, do you think after we doing the atherectomy, we check the IVUS, how many lumen gain you are satisfied and you will go ahead dry effusion balloon? Another question is that do you ever combine different type of atherectomy device during your clinical practice? And okay, and the third problem is, do you have any experience about the IVL for the eccentric plaque in the peripheral artery disease? Thank you.
Yes, first of all, the IVL is not available in South Korea. Maybe 1 or 2 years later, it is possible to use in South Korea. In my personal experience, I have more than 15 years of experience of the directional atherectomy. I think there is a different indication of the atherectomy in the peripheral artery disease. Hook 1 is better in eccentric, especially in the heavy calcification, especially in the common femoral artery, I think. But in terms of the rotational atherectomy, such as the jet stream, it is better to use in case of the concentric disease and the CTO lesion, especially while in the intraplaque. But in my personal experience, when I performed the Hook 1 atherectomy in CFA, especially the eccentric lesions, I did atherectomy more than 20 times. Recently, my personal record is 52 times in atherectomy in the CFA with the Hook 1. But commonly I use more than 20 times in CFA for atherectomy with the Hook 1. And in my personal experience, the rate of the IVUS is around 10% in the peripheral artery disease interventions. But when I meet the CTO region, especially in the iliac and the distal separae and the punctural artery, I want to use IVUS because of checking the wire locations. And sometimes when it was very hard to advance the wire to penetrate the CTO region, I use IVUS guided wiring. That is the most frequent situation to me to use IVUS in peripheral field.
Okay, thank you, Dr. Kim. Very beautiful result, very nice case. Thank you and congratulations.
Thank you very much.
Okay, we move to 中国 room 1. 典玉. Okay.
The second case is successful retrieve, right? You see that? We all see that. It's broken, but I think it's also successful. But the third case is very difficult, right? Because the IVC filter is tilted and to the renal vein. And the difficult part is I cannot looping the central part of the IVC filter. So my plan is to try to lock as possibly as the central part of the IVC filter. I mean the top of the IVC filter. And then we try to remove. 哎，等下，先把我外拉出来。那你先把外拉出来，我才能够拉下去。对，拉出来，拉。sorry，等一下。So for the safety, we also puncture the leg. It's not usually need to puncture the leg.
So this is not the record image. You are doing this case now. Okay.
Right. Yeah. Right now. So a little bit harder, right?
So
I need to loop. I make a loop.
We still have 3.5 minutes. So our panelists do have any comment for this case? Any idea?
Yeah. Actually, I try to make a loop to the renal vein, but cannot pass the filter. Though you see the fatty head is in the renal vein, but it's not here, right? Not there, and cannot make a loop. Can be retrieved.
So, Dr. Rockman, do you have any idea?
I maybe because that catheter can go to engage at the lateral side of the IVC wall. The hook is tilting, so maybe in my idea I will change the catheter of the snare to the angle catheter like the JR4 6 French and try to engage to catch the hook. Because right now it's tilt and the snare cannot reach because it's the straight catheter. It cannot reach to the lateral sides. Maybe. Or maybe use the balloon from below to make it tilt back. Yes. Otherwise, we need the forceps.
Oh, forceps, yes. So, maybe Dr. Lee, you have the experience about forceps.
Yes. From our experience, maybe in this scenario, maybe I'll use a curved sheath. Use a curved sheath and use forceps. And use a curved sheath, it can direct your the forceps to the hook area. Then you use the forceps to directly grab the hook, then trying to remove.
Yeah, maybe use hook. Use forceps is another best way, but.
My experience with the Denali filter like this, because Denali have their double filters. So at the upper part of the filter is very soft and it's very easily for destroy or kinking or deform. One of my junior colleagues tried to do in this way, and the filter is floating up nearly into the RA. So maybe you should back up or be careful in that case also.
Yes. And because we start this section delayed, so they say we still have 10 more minutes. So now we move to Zhongguo Room 2, Dr. Pan and Dr. Lin. Yes.
Can you hear me?
Yes, please.
Yeah, we are having a rather difficult case, but eventually we managed to cross it's quite a tough lesions and tough occlusions which we couldn't cross initially, and then subsequently we used the 018 wire and 6i, and with some luck we managed to cross it. But the problem is we don't have the IFRS working today here in room 2. So we just use the CT as a sizing. I have pre-dilated lesions with 6 millimeter and 8 millimeter balloon. Now we implant the first stent by using.
Dr. Pan, could you show us the initial venography?
Yeah, we can show you the venography. Can we have the venogram? Can we show the venogram previously done?
哦，对对，再往前那个有 N9的，因为找
不是这个，在之前的，在之前的。
刚开始的，刚开始的。
不是这个，不是这个。就是的 lesion 就是在这个 femoral head 的时候开始，那一直的一直是堵到，就是 the occlusion is from femoral head all the way up to the IVC.
Yes, very, very severe occlusion.
Yeah, we have tried some different catheter and sheath as support, and now the wire used is a Terumo Advantage wire. It's a composite wire with the first 25 centimeters hydrophilic wire, and with a supported more stiff shaft from the 25 cm onwards. I even use this wire as a support for doing the stenting. Now we plan to have the second stent. And this RB stent is quite a good device, which is a triaxial system, which is quite stable, and we don't worry about the jumping of the stent. So I can show you the first stent we placed. Yeah.
So this is a chronic case. Did you see any fresh clots in the deep vein?
You mean the?
Any fresh blood clot?
No. There's no blood clot noted, but it's just very fibrotic, very difficult. Even for the CXI, the 2.6 French CXI is very difficult to cross.
Yes.
Can we have the 19 centimeters the sheath? We can use as a contrast injection. I can show you the contrast. We are now prepared to place the final stent. I think one of the important point is for treating this chronic case is the stenting has to be start from a healthy segment to healthy segment. Because in the past we probably just avoid stenting too much. But for these sort of patients, I would suggest to stent from the, usually we stent across the femoral head even. Just like this case. Can we have the sheath?
Hi, Dr. Sky.
Sorry,
Shai here. Can you tell us a bit about the sizing of the stent for the like the common iliac vein, external iliac vein, and common femoral vein?
Yeah, I think that's a very good question. For this case, ideally, I think it's good to have IFRS to have a better sizing. But because this is not working, despite we have opened a few pad of the IFRS catheter, so I decided to use the CT as a reference, or use the right side as a reference. So the right common eyelid ring is around 15 to 16 millimeter. So I just place the proximal part of the first stent is 16 millimeter. The second one is 12. And now I plan to have another stent, probably 10 millimeter will be sufficient.
Thank you. For the first stent, you need the long stent like 10 or 18, 100 or 18 or what do you think?
Sorry?
I mean,
for the first stent.
For the first stent, you prefer the longest one, like the 100 or 120, or is the
ideally, I think it's better to have 80. Is usually 80 or 10 centimeters. But we won't. I won't balloon up to 16 millimeters. So I think it should be all right. But of course, another concern is the cost. So now, because of the lesion, we probably need to have a free stent. We also, for this kind of wing stent, I usually overlap a little bit more, like 2 to 3 centimeters. Can we have maybe 10? I think 10 is okay. Can we have a 10 times 8 millimeters? 8 centimeters stent? 10 millimeters, the RB stent. Shorter, 80.
So for adequate inflow, you have to put your stent across the femoral head, right?
Yes. So we are now putting the probably the final stent, and then we can slowly balloon because the patients feel quite painful during the balloon angioplasty. I think because of the size of the femoral and the external iliac wing is not very big.
In some meta-analysis show that if you want to cross the inguinal ligament, you need the strong stent.
Yes.
I think every is quite strong.
Yes, I think there is different bare metal stent for the these sort of situations. RBA is having a better compression resistance and also radial strength when compared to different other competitor. So I think this is also very stable platform with a large range of size and length. Okay. So can we have 10 millimeter balloon? Now we will gradually upsize the. Okay, we will gradually upsize the stent. So because we don't have the IFUS, so in this case actually before we puncture the popliteal wing, I have punctured the right femoral wing. That's why we have other assets we can inject the contrast via the right femoral wing, and then while during the stent deployment, I can have the contrast injection from the right femoral sheath such that I can know the IVC. Where is the IVC? We can have a more precise landing on the proximal path. Of course, I think that ideally we should use the IFUS in this case, but unfortunately it's not working.
Okay, Dr. Pan, we have only 1 minute left, so we are going to close this section. Do you have any words for us?
I think maybe we can before ballooning we can see the flow. Maybe we'll give one angiogram and see how it's.
Okay, please.
Doing. Yeah. Okay. Oh. Not working very well.
Maybe.
Maybe too. Okay.
Yeah, maybe still the inflow problem.
Yeah. Yeah. maybe. And also there's a lot of collaterals. There might be some venous stasis. So I think I still need to open up the stent, make sure that the adequate expansion. But I think the distal part, the landing of the stent over the femoral head should be sufficient.
Okay.
But if not, we probably need to add another one. But I hope we don't need to. Balloon, please.
Okay, thank you, Dr.
Yeah, I think
Pan.
that's all.
We will see the result in the next section. And
Okay.
I have to thanks all the operator today and all the panelists.
Okay.
And thank you. Okay. Please, all the audience, we have the picture together. Maybe we go downstairs. Please, all the audience, yeah.